Today we will be talking about ischemic and hemorrhagic strokes based on the hard work of Lloydete, Dena, James, and Miranda. Cerebrovascular disease is the most frequently occurring neurological disorder. This includes any abnormality of the brain caused by a pathologic process in the blood vessels. We will be discussing two different types of cerebrovascular diseases, which includes ischemic and hemorrhagic stroke. Let's begin by speaking about statistics of cerebrovascular accidents, otherwise known as CVAs. CVAs are the third leading cause of death in the United States, resulting in 143,600 deaths per year. CVAs are also the leading cause of disability in the United States, with 50% of individuals experiencing some level of disability after 6 months of onset. The occurrence of a stroke is often debilitating. Studies show that 50% of patients who have a stroke will not be able to return to work. 15 to 30% of those patients are permanently disabled, and 20% require institutional care at just 3 months after onset of a stroke. A stroke reflects a loss of muscle function, mental function, vision, sensation, and speech, resulting from brain cell injury caused by an insufficient supply of blood to a part of the brain. There is also an age, race, and gender relation, whereas 50% of CVAs occur in persons over 70 years of age, although 28% of individuals younger than 65 years of age experience a stroke. There is a large association with familial history related to stroke occurrence, as stroke prevalence is 2.5 times higher in blacks than whites, with the prevalence being higher in black women than black men. Strokes also occur in children, where risk factors and causes are different from adults. Some causes include congenital cardiac disease, sickle cell disease, arterial dissection, prothrombotic disorders, moyamoya disease, and head and neck trauma. Vascular occlusion occurs more often in intracranial vessels, including the internal carotid, middle cerebral, and basilar arteries. Infarcts more often limited to deep regions of the cerebral hemispheres, mostly basal ganglion and internal capsule areas. Intercerebral hemorrhage and subarachnoid hemorrhage amount for a much higher percentage of strokes in children. There are multiple risk factors that are associated with stroke, including atrial hypertension, as well as elevated systolic and diastolic blood pressures, which are independent risk factors. Smoking doubles the risk of a patient to have a stroke, whereas diabetes is an independent risk factor and increases the risk of ischemic stroke between 2.5 to 3 times more. Polycythemia and thrombocythemia increase the risk of ischemic stroke, as well as hypercholesterolemia and impaired cardiac function, such as atrial fibrillation and hypertension. Stroke risk is also higher in people who have heart disease or poor blood flow into their legs caused by narrow arteries. As well, people who have unhealthy lifestyle habits such as smoking, diets high in fat, and of lack of exercise. Women who take birth control pills are also at risk, especially those who smoke and are older than 35. Research has shown that anti-diabetic, anti-hypertensive, and lipid-lowering therapies significantly reduce the risk of ischemic events. But long-term adherence to these medications is poor, as research shows that 50% of patients do not take their medications as prescribed. Now let's delve a little more into ischemic stroke, also known as embolic or thrombotic stroke. An ischemic stroke arises from arterial occlusions caused by thrombi formation in the arteries supplying the brain or the intracranial vessels, most frequently attributed to atherosclerosis and inflammatory disease processes that damage arterial walls. Conditions that also cause inadequate cerebral perfusion increase the risk of thrombus, which includes dehydration, hypotension, and malignant hypertension. Over the years, plaque tends to adhere to the vessel walls, causing stenotic lesions, which forms an ulcerated area on the wall of the vessel. Platelets and fibrin adhere to the damaged wall, and clots form, gradually occluding the artery, also known as the thrombotic stroke. These fragments usually form outside of the brain, heart, aorta, or common carotid artery. Portions of the clot break off and travel up the vessel to distant sites where occlusion occurs and causes an embolic stroke. It is also important to mention TIAs, or transient ischemic attacks, when talking about ischemic strokes. A TIA is a brief episode of neurologic dysfunction caused by a focal disturbance of brain or retinal ischemia with clinical symptoms typically lasting less than an hour and without evidence of infarction. Pathophysiologic effects for ischemic stroke include that ischemic infarcts are pale infarcts, or white strokes, which are cytotoxic ischemic events, and interaction between the blood elements and blood vessels combine to produce a brain injury. The affected area becomes discolored and softens about 6 to 12 hours after the initial occlusion. Necrosis and swelling continues 48 to 72 hours after infarction, and neural damage can occur. Cellular and biochemical events then follow. For example, loss of glucose and oxygen to the infarcted area, and a loss of autoregulation of blood flow. Capillary sprouting then can occur to the surrounding areas. Common differentials for ischemic stroke are based on the signs and symptoms that are presented by the patient. This includes Bell palsy, brain neoplasms, conversion disorder in emergency medicine, hemorrhagic stroke, hypoglycemia, migraine headache, a seizure assessment in the emergency department, emergent management of subarachnoid hemorrhages, syncope, and transient global amnesia. This is why further testing is important. Now let's talk about hemorrhagic strokes, otherwise known as intracranial hemorrhages. Hemorrhagic stroke is the third most common cause of CVA and accounts for 10 to 15% of strokes in white Americans and 30% of strokes in black and Asian Americans. The most common causes are hypertension, where patients have this 56 to 81% of the time, ruptured aneurysms, arteriovenous malformation and fistula, amyloid angiopathy, and carnivorous angioma. It can also occur secondary to traumatic brain injuries, bleeding disorders, or anticoagulation. This type of hemorrhage is associated with a significant increase in systolic and diastolic pressure over several years and usually occurs within the brain tissue. A mass of blood is then formed, and its volume increases. Adjacent brain tissue is displaced and compressed, and rupture or seepage into the ventricular system then occurs. Bleeding continues into the brain tissue, cerebral perfusion decreases until it completely stops, causing death. Adjacent blood tissue is deformed, compressed, and displaced. Necrosis begins after 6 hours. Edema then forms, and the blood-brain barrier is disrupted. Then, the inflammatory reaction in surrounding brain tissue appears rapidly. The hemorrhage resolves when reabsorption occurs. This is usually due to when surgical intervention is often required to evacuate the hematoma. Now let's talk about the pathophysiologic effects for hemorrhagic strokes. A hemorrhagic infarct are considered red strokes, where bleeding occurs into the infarcted area as a result of restoration of blood flow. The pathogenesis of hypertensive cerebral hemorrhages is not fully understood. Smaller arteries and arterial vessel walls thickens and increase hyalinization. Necrosis may or may not be present, but precipitates the bleeding. A mass of blood forms in brain tissues and creates necrosis around the hematoma within the 6 hours. An inflammation surrounds the brain tissue and peaks within a few days. Reabsorption of the blood could occur by macrophages and astrocytes activities, also sometimes including surgical intervention. Now let's talk about common differentials for hemorrhagic stroke: encephalitis, migraine headache, hypernatremia, hyperosmolar hyperglycemic non-ketotic coma, hypertensive emergencies, hypoglycemia, hyponatremia, labyrinthitis ossificans, meningitis, brain neoplasms, ischemic stroke, subarachnoid hemorrhage, subdural hematoma, and transient ischemic attacks. How many can you name that are similar to the ischemic stroke? The diagnosis and treatment of stroke has a long history, dating back to 460 BC, where apoplexy, known as being struck down, was a sudden versus focal disorder. It was believed that spirits were being kept from the brain ventricles instead of having an anatomy problem. In 1936, the cerebrovascular accident, or CVA, was coined, and although many scientists don't use the term accident anymore because it was found there could be things done to prevent and treat a stroke. In 1973, the CT scan was developed and was used in diagnosing hemorrhagic strokes. In 1982, performing an endarterectomy was uncertain. In 1990, platinum coils were used to embolize intracranial aneurysms. However, the stability of these coils were still uncertain at this time. In 1996, the FDA approved TPA medication for ischemic strokes. And in 2003, UCLA was researching whether patients receiving magnesium, a vasodilator, within 12 hours of onset of symptoms benefited with smaller infarcts. And including up till today, stroke studies continue with advancing technology. When talking about pathophysiological clinical signs and or symptoms of either ischemic or hemorrhagic stroke, the symptoms of stroke depend on what part of the brain is damaged. In some cases, a person may not know that a stroke has even occurred. Most of the time, symptoms develop suddenly and without warning. However, symptoms may occur on and off for the first day or two. Symptoms are usually most severe when the stroke first happens, but they may slowly get worse. A headache may occur if the stroke is caused by bleeding in the brain. The headache starts suddenly and may be severe, occurs when the patient is lying flat. It can wake up the patient from sleep, and it can get worse when the patient changes positions or when they bend, strain, or cough. Other signs and symptoms depend on, again, how severe the stroke is and what part of the brain is affected. Symptoms may include changes in alertness, including sleepiness, unconsciousness, and coma, changes in hearing, changes in taste, and changes that affect touch and the ability to feel pain, pressure, or different temperatures. Clumsiness, confusion or loss of memory, difficulty swallowing, difficulty writing or reading, dizziness or abnormal feeling of movement, sometimes vertigo, lack of control over the bladder or bowels, a loss of balance and coordination, muscle weakness in the face, arm, or leg. Usually this is just unilaterally, and numbness or tingling on one side of the body. Personality, mood, or emotional changes. Problems with eyesight, including decreased vision, double vision, or total loss of vision. Trouble speaking or understanding others who are speaking. And trouble walking. The nurse practitioner's management of goals and strategies. Let's first start with ischemic stroke. Time is brain. Treatment should be initiated within 6 hours of the onset of symptoms to prevent irreversibility of brain ischemia. Specialized stroke rehabilitation is most effective in reduction of death, dependency, and prolonged hospital admissions. Aspirin or systemic anticoagulants, unfractionated heparin, low molecular weight heparin, heparinoids, oral anticoagulants, or specific thrombin inhibitors when given within 48 hours of ischemic stroke has shown to be effective in reducing death at 6 months. Antiplatelet treatment also reduces the risk of recurrence. Anticoagulants have not proven to be effective in reducing the risk of recurrence unless the patient is in AFib. Otherwise, it increases the potential for intracranial and extracranial hemorrhage. Thrombolysis, TPA, is given within 3 hours of onset or symptoms of ischemic stroke. It decreases dependency at 6 months. Also, lowering blood pressure reduces the risk of serious vascular events regardless of the etiology of the stroke. Carotid endarterectomy in cases with more than 50% carotid stenosis effectively reduces the risk of recurrence. Cholesterol reduction using statin drugs are effective in reducing primary or recurrence risk regardless of baseline cholesterol level or coronary artery disease status. Carotid and vertebral transluminal angioplasty is a newer treatment to reduce recurrence. However, its efficacy is not yet available due to insufficient evidence. Now, nurse practitioner management goals and strategies for hemorrhagic stroke. The primary goal in an intracranial bleed is to focus on stopping the bleeding, controlling the increased intracranial pressure, and prevention of a rebleed and vasospasm. Occasionally, an evacuation or aspiration of the blood is attempted. Other surgical procedures are necessary, maybe an aneurysm clipping, coil embolization, and arteriovenous malformation repair. Blood pressure medications and lifestyle changes, smoking cessation, dietary changes, exercise, and ceasing any illicit drug use, including alcohol, are most helpful in reducing risk. And if the patient is on an anticoagulant, it should be stopped. And of course, it's important to use the NIH stroke scale pictured here, as it is used to assess the severity and improvement of the patient's stroke. When talking about effective management of goals and strategies, it is also important to mention methods that are proven ineffective in the management of strokes. In acute ischemic stroke, acute lowering of the blood pressure may increase cerebral ischemia. Neuroprotective agents have not been proven to significantly reduce the risk of poor outcomes such as death or improve outcomes with ischemic stroke. Surgical evacuations may be indicated in only a few specific situations. However, it has not been shown to be effective in the treatment of intracranial hemorrhages. And finally, complications for both ischemic and hemorrhagic stroke. Mortality can occur from any type of stroke, mostly within the first 6 months of onset. Reoccurrence of the stroke or a TIA, intracranial aneurysms, intracranial or extracranial hemorrhage, a disability from a physical or mental standpoint, side effects from new medications, alterations in activities of daily living, a dependency due to a disability, which they may need a caregiver or assistance of some sort, and of course, medication dependency is also a possibility. And finally, financial and transportation issues for needs such as rehabilitation, testing, in-home care, or a skilled nursing facility.